Hi everyone, I'm Ashwin,
I'm Raj.
and this is Blood Cancer Talks. We are a podcast dedicated to hematologic malignancies, where we bring content experts who live and breathe a particular disease and focus on latest advances in biology and clinical management. Please take a moment to rate and review our podcast in whichever app you listen to your podcast in. Today, we are excited to review the hottest updates in myeloid space from American Society of Hematology annual meeting, which was held in San Diego in December 2024. We are delighted to be joined by Dr. Jayastu Senapati. Jayastu is an assistant professor in the Department of Leukemia at the University of Texas MD Anderson Cancer Center in Houston, Texas. He's an astute clinical investigator in myeloid space. Jay Stu, thank you so much for joining us. Let's talk about the some of the ASH updates. But before we delve into it, and can you maybe give us a brief introduction about you and what is your clinical and research focus?
Thank you, Ashwin. Thank you, Raj, for considering me for this blood cancer podcast. I have been listening to Blood Cancer Talk for a while now, and it's very highly rated in the community, of course. Very glad to participate on this platform for the ASH 2024 update in the myeloid space. I'm an assistant professor in leukemia at MD Anderson. Very glad to be here. My research focus is in acute leukemia, AML, and ALL space, like particularly the AML space more, and eventually to develop new drugs in this space, run clinical trials. As of now, I have been looking at some of the genomic markers of resistance and sensitivity to venetoclax-based therapy, and the post-hoc analysis of multiple clinical trials, as well as published on some early phase clinical trials. Again, very happy to be here, and thank you for including me.
You have many abstracts at ASH, and we'll talk about some of the abstracts as well along the way. First, to start with, ML was a very hot topic at ASH. So, first, to start off with, I think let's delve into older AML. I think there were a couple of abstracts which were thought provoking as well as potentially in the future could be practice changing. I think
Sure.
the biggest is the older AML where the age cutoff for inclusion in the VIAL-A study, which led to the FDA approval of Venetoclax plus HMA, used a
Yeah.
cutoff of 75. But we know, the treating physicians know that even in patients between 60 to 75, we always struggle to give intensive chemotherapy, especially
Correct.
patients who have a lot of comorbidities.
Yes.
And we in these patient populations, we actually go with Ven-based HMA, even though those were not included in the VLA study.
Right.
So, two studies which were quite thought-provoking and provided insights into this. One is a retrospective analysis, which showed that Venetoclax plus HMA was comparable to standard intensive chemopherapy. And there
Correct.
was a randomized phase 2 trial which also showed that when HMA is comparable to 7 plus 3. So,
Yeah.
Jayestu, what is your take on these two abstracts?
Yeah.
One, yes, a retrospective analysis, but I think the randomized phase 2 trial is quite exciting.
Right. So just to give a little background, in our practice at MD Anderson, for patients who are above 60 years of age, for the most part of it, we have moved away for intensive induction chemotherapy. Our frontline intensive induction chemotherapy are dual nucleoside with anthracyclines, or CLIA-Ven or FLAG-Ida-Ven. And of course, in CBF space, it's a completely different ballgame. We can talk about it. Our mutation agnostic approach is the semi-low intensive combination of cladribine, low-dose itrabine, and venetoclax, which alternates with decitabine venetoclax led by Tapkadia in our group. Fantastic results was updated at ASH as well, focusing on patients who are more than 60 years of age, CRC rates upwards of 90% almost, deep MRD negative rates, and 2 years RFS in the range of over 60%. Again, this is specifically in patients who are more than 60 years of age, usually do not have a FLT3 mutation, usually do not have IDH1 or 2. So these are very promising results already. Now, certainly, in the community, HMA-Ven is the approved regimen for patients more than 75 years of age, thanks to the VIALE studies, which did not include patients below 75 if they were fit. So they did include patients who are less than 75 who are probably unfit. Now, the question is, in the very important age group of 60 to 75, where you will see a huge chunk of AML patients, do you take them towards the intensive chemotherapy approach, or do you take them to the low intensity approach? And as we're improvising on low intensity chemotherapy approaches, I think a lot of these patients are going to see these low intensity approaches. Now, if we stick just to HMA plus Ven, when the update of the VLA was done by Dr. Keith Pratt's, you see the median survival is still 14.7 months, significantly better than HMA alone, but there is so much more room for improvement, as you know. Now, certainly HMA plus Ven comparing to 7 plus 3 would be the ideal place to start with, but are we using the right comparator arm in the first place? Now, the prospective study, I think that was from China, that was a phase 2 randomized controlled trial. They looked at patients who were less than 60 years of age. 7 plus 3 plus HMFN. And I think there have been similar outcomes, except in the CBF space. As we know for sure, CBF AML is a group where we would not like to de-intensify therapy. Venetoclax has not really done that great in the CBF space as well. So short of that, a lot of patients did well already when they were given HMA plus vein-based therapy when compared to 7 plus 3. The question is, how do you consolidate these patients after they receive HMA plus Ven? So that brings me to the point, is the quality of MRD negative remission post HMA plus Ven similar to after intensive chemotherapy, especially in patients who have reasonably sensitizing mutations like NPM1 and IDH2, maybe even secondary group mutations, which are known to be Venetoclax sensitizing? Do we continue these patients on Ven-HMA, or do we take them to transplant? Do we intensify the consolidation? Because there have been some approaches that are now doing a low intensity approach, stabilizing the patient, bringing them to remission, and then consolidating them with intensive chemotherapy as a one-time approach. Those questions still remain unanswered. Now, certainly in patients who are more than 75 years of age, where intensive chemotherapy is almost never pursued, HMFN still remains the single most important treatment modality, though again, in our group, we do it a little differently. But 60 to 75, I think it's good and promising results that we should still move to HMA plus Ven, but it's still too early to think that this is the most definitive regimen. We should look at dual nucleoside-based low-intensity regimens like cladribine, low-dose Ara-C, Venetoclax, and more importantly, understand what is the quality of the MRD negative remission after these low-intensity approaches.
Yeah, those are fantastic points. There was another abstract as well, I think, which is very preliminary, of course. Only 28 patients were reported, looking at Ven-Aza versus 7 plus 3 in younger patients, so less than
Right.
60 is what they included in
Correct.
that abstract. Although, as you said, it's only very few patients, so it's very preliminary. But I think once again, it is quite thought-provoking that when HMA is comparable, even though in a very small cohort of patient population who
Correct.
are younger than 60.
Yeah, I want to, if I have a minute, highlight this point as well. Meaning, this was meaning led by Dr. Dan Polya, a wonderful analysis. Unfortunately, they had to modify the study to remove monocytic AML, and now we know for sure that it's not the monocytic AML per se which defines venetoclax resistance, but the RAS pathway mutations. Just a couple of months ago, a wonderful Nature paper led by Dr. Konopleva and others that showed that the RAS mutations actually dictate the phenotypic shift towards monocytic AML, which again mediates the resistance to venetoclax-based therapy, and RAS pathway mutations are included in the ELN 2024 risk stratification as one of the hazardous mutations. But again, talking about this MRD issue in older patients and type of therapy, if we have an MRD negative remission, and if the patient is going to transplant, does the type of therapy prior to transplant really matter? So I think in this abstract, 60% and above patients could proceed to transplant, which is a very high number. But we did publish in an analysis, which was a post-hoc analysis of our CLAD-LDAC-VEN study, and compared them to patients who were more than 60 years of age who underwent transplant after HMA-Ven, and we did see significant difference in survival outcomes despite all these patients proceeding to transplant. And that difference was more between Clad-Ven and HMA-Ven, and still slightly lesser between Clad-Ven and intensive chemotherapy. So certainly the type of therapy prior to transplant, even if you're MRD negative remission, might have a role. I don't know why, but we will have to see in prospective studies. Yeah.
I had a quick follow-up question about the randomized phase two trial from China that
Yeah.
compared Ven+HMA versus 7+3. Just for the audience, what was the primary endpoint of that study? And then the second thing is, like, what was the patient population? Was it only 60 to 75, or did they also include less than 60? Just to clarify that a little bit.
Yeah. So the primary endpoint of that study was actually, to the best of my knowledge, was remission assessment. So complete remission and complete remission with incomplete hematological recovery. And the secondary endpoints were the usual event-free survival, overall survival, and MRD negative remission rates. Well randomized sets with no significant difference in baseline variables. And the study population included patients basically who were 18 to 59 years of age and eligible for intensive chemotherapy because the comparator arm was 7+3.
Okay, so yeah, that's important because the primary endpoint was not survival. So that's why you
Certainly
raised the
not.
point that
Yes,
even if the CR rate was similar, it's possible that
correct.
the quality of the MRD may be different, and in long term, the survival may be different. We don't know.
Yes. And we have learned this in the ALL space. Now in AML, only for very few mutations, we have deep sequencing for MRD available. But in ALL, where we do NGS-based assessment, we now know a lot of flow cytometry MRD negative ALL are still NGS MRD positive, which actually defines better prognosis. In the AML space, we are at lack of it. Maybe some groups are developing it. So the quality of MRD is, of course, difficult to predict in the AML space. And so we cannot use just MRD negative remissions, etc., as surrogates for survival thus yet.
Now, let's talk about some of the intensive therapy treatment options. There was a prospective study reported at ASH this year in which, Jayastu, you were the first author that compared FLAG plus GEO versus FLAG IDA. And it showed that FLAG GEO led to superior molecular response and survival outcomes compared to FLAG IDA in 200 patients on long-term follow-up. As we know, core binding factor AML is considered favorable risk with high survival rates using intensive chemotherapy, and adding GEO has shown superior molecular responses. So can you summarize the results of this abstract, and why do you think this abstract is practice changing?
Thank you, Raj, for bringing up this abstract. So, in short, this is an ongoing phase 2 study that includes all adult patients with core binding factor acute myeloid leukemia. The study is primarily fludarabine, cytarabine, GCSF with gemtuzumab ozogamicin. For a brief period of time, when gemtuzumab was taken off the US market for concerns of hepatotoxicity, we had to replace gemtuzumab with idarubicin, which gives us the capability to compare these two treatment arms in the same study. And then now again, gemtuzumab got reapproved, so it's back. So this is a 200-patient, pretty good long-term follow-up data of this still ongoing study. So high-intensity therapy in CBF AML space have been shown to be the gold standard. With 7+3 5-year survival ranges at around 50 to 60%. With fludarabine Ara-C dual nucleoside analog-based therapy, we have seen this going upwards of 60-65%, and especially with patients who receive gemtuzumab ozogamicin, which was actually shown in multiple studies to be the most effective in patients with intermediate risk AML and favorable risk, particularly CBF AML. When we combine a FLAG with GO, our 5-year survival rate have been upwards of 70-75%. So, which is a very promising figure, considering that this is across the age group. Now, what we are now trying to further analyze, given the ability to compare the two treatments, essentially idarubicin or gemtuzumab added to the FLAG arm, does gemtuzumab really predict better and deep responses, the cadence of the responses, and the long-term survival outcomes? And we have published this before briefly that with gemtuzumab, we are able to get more optimal PCR-based responses in these patients. And the optimal response is usually defined by less than 0.1% after induction and less than 0.01% during or after consolidation of the CBF-specific transcripts. So with gemtuzumab added to FLAG, these rates are higher. Often these rates are quicker, and the RFS is also much better with FLAG-Go than with FLAG-IDA. The OS tends to be better, but we need longer follow-up for that. Now, in patients who are more than 60 years of age, of course, we cut down the dose for every decade of life. So 33% reduction for 60, 70, 50% reduction for 70 and above. And certainly their survival is still shorter than that it would be for patients who are less than 60 years of age, but we are still seeing 5-year survival upwards of 50 to 55% in the older age group as well. So with gemtuzumab-based therapy, we are seeing deeper and quicker optimal PCR responses and better survival than FLAG-IDA-based therapy. Now, when we compare patients who have equally good PCR responses between the FLAG-Go and FLAG-IDA arm, there is a trend of the GEO still doing better, even with patients who have equally good PCR responses. So in our future efforts, actually, we are working on this. We are putting together the concurrent mutational profile. So CBF AMLs have been known to have associated mutations in the kinase pathway, particularly KIT, RAS, FLT3, and also some DNA methylation pathways. And does that affect the cadence of the PCR responses and long-term survival? So several groups have shown that KIT mutations could predict a shorter relapse-free survival, lesser chance of MRD negative remissions. When we published this a couple of years ago, we have shown that with gemtuzumab added, the effect of these mutations might not be as negative, but we have now done much better sequencing, and we're going to put that data together in the next few months.
Fantastic, Jayastu. On a follow-up question, I know core binding factor is a quite a heterogeneous group. You
Yeah,
see in version 16 as well as translocation
right.
821. Have you seen any differences in terms of MRD in version 16 versus translocation 821?
Not with FLAG-GEO. So the effect of additional cytogenetic abnormalities, other mutations, primarily FLT3 RAS, and the type of CBF did not predict survival or the frequency of optimal PCR responses when gemtuzumab was added to FLAG-GO. So to speak, gemtuzumab does a lot of the good work in this combination, and we are trying to see in putting together much more of the mutational profile and see if there are any specific mutations, what's the VAF of these mutations, and if that could predict. And I don't yet have the answer, but we'll have it soon.
And any toxicity differences between flag geo versus flag ida?
So the major concern is of hepatic sinusoidal obstruction syndrome, especially if any of these patients are proceeding to transplant. So we have not actually seen any episode of SOS in our study with the GEO arm. Uh, and the way we do GEO is, the first cycle patients get a flat dose, meaning 3 mg per meter square, but capped off at 4.5 mgs, and then 2 further doses during the consolidation cycles. We believe thus far that the early introduction of gemtuzumab during induction is very important. Subsequent addition of gemtuzumab might not lead to as good a leukemia cell kill as an earlier introduction would. We have not seen particularly super high toxicities with this. Certainly, the duration of cytopenia is longer when you add either idarubicin or gemtuzumab to flag. So approximately 35 to 40 days in induction. Could be the time point of neutrophil recovery. But again, the doses are adjusted based on age, and patients do get prophylactic growth factor injections.
Now moving on to talk about secondary AML. I know
Right.
that you had an abstract about secondary AML, which we can talk about, but I also want to mention about CPX351,
Sure.
which is the only FDA-approved medication for secondary AML.
Right.
So CPX351, and just as a background, was FDA approved for secondary AML, and FDA label is for therapy-related AML as well as AML with myelodysplasia related changes. This is based on 2008 WHO classification, but those categories no longer exist in the most updated 2022 WHO as well as ICC classification. So right now, I think we as a treating physician sort of struggling which patients to use CPX351. I think
Right.
two abstracts at ASH shed a light on this. The first abstract from which showed a subgroup analysis of UK NCRI AML 19 trial, which is a randomized comparison of CPX and FLAG-IDA in patients with high-risk AML
Right.
and MDS, and they also include patients who had MDS-related gene mutations. So this was a post hoc analysis. This was a subgroup analysis of the entire clinical trial, so there is a lot of limitations exist.
Sure.
But I think, in my opinion, it's quite thought-provoking. There were 59 patients with MDS-related gene mutations, which is defined as presence of ASXL1, BCOR, EZH2, RUNX1, SF3B1, SRSF2, STAC2, U2AF1, or ZRSR2. They excluded T53 mutations in this analysis. This
Right.
is per the ICC classification, which groups T53 as a separate category.
Correct.
So in this, 30 patients were randomized to 6 CPX351 and 29 to FLAG-IDA. One interesting thing about the abstract was the overall response rate was lower in CPX351 compared to FLAG-IDA, but there was an overall survival benefit, about 38.4 months with CPX versus 16.3 with FLAG-IDA. I
Right.
think this was quite interesting to see that the differences between the overall response and median overall survival. So, Jayastu, how do we reconcile these differences? And do you see that CPX351 as a emerging treatment options for patients who have MDS-related gene mutations?
Thank you, Ashwin. Very important area, I feel. We are going to see more and more secondary AML, as well as therapy-related AML, as patients are living longer post their primary other cancer, non-myeloid malignancies. So the entire world of secondary AML went for a toss when WHO and ICC came up with these proposals, which are very nuanced proposals, I feel. So initially, it was only clinical secondary AML. If a patient has had a prior diagnosis of MDS, MPN, aplastic anemia, etc., then we started looking at AML with myelodysplasia-related changes based on morphology, which probably didn't hold the test of time with modern therapy, but had prognostic implication when patients in the past were treated with intensive chemotherapy. They had more cytopenias and probably slightly inferior survival. So just based on morphology.
Mm.
Now, a very genomically inspired approach in which the morphology takes a lower stand. It's still important, I guess, but we are looking at mutations. But what often we don't add to this discussion is the cytogenetics as well, which the ICC and the WHO propose. It's a plethora of cytogenetic changes, including complex karyotype, including plus 12p. Very varied group. Complex karyotype we know do poorly, whereas some of the other cytogenetic changes like -5, -7, they are still adverse, but not in the same bandwidth. Okay, so I just wanted to add that. The second point is both these abstracts miss on the Venetoclax aspect of it. If you're looking only at myelodysplasia related mutations, there is enough translational evidence now, as well as clinical evidence to see that Venetoclax based therapy, these mutations are sensitizing to Venetoclax based therapy. We showed that in the case of splicing factor gene mutations, which are actually one of the most common secondary type mutations that Venetoclax based therapy leads to significantly improved survival, maybe even more than patients who do not have these mutations. And there were elaborate work done in Dr. Omar Abdul Wahab's lab that showed that these splicing aberrations lead to Venetoclax sensitivity. Amit Verma's lab showed that ASXL1 mutations lead to Venetoclax sensitivity. And several other studies and other groups have shown that these secondary group mutations lead to an improved responses in patients with both high-risk MDS as well as an AML. So that's the background. Unfortunately, both these studies do not include that. So CPX in the secondary AML space without previously known genomic changes was approved and it had showed survival benefit. Of course, this was not true for patients who had previously received HMA for their MDS CMML. If we go into the exploratory analysis of the registrational trial for CPX, we will see that the survival difference waned when patients who had received prior disease-modifying therapy for their MDS was included. So CPX and standard of care chemotherapies fared similar to each other. Now, the industry-driven study from as the post-hoc analysis of the UK NCRI AML-19 trial, very interesting results. Certainly, responses are lower with CPX, but the quality of these responses are good. Just alluding to what I was speaking before, FLAG-IDA more intensive than CPX for sure. So as a result of which, you're probably getting higher responses, but these might not be very durable or good responses. But once you hit response for CPX, you're already selecting patients who are sensitive to CPX, and that defines the better relapse-free survival and overall survival to the best of my understanding, given the limited data on the abstract. What I would like to see, however, is the difference in the cytogenetic component between these two groups. So MDS-related mutations could occur without any of the MDS-related cytogenetics, and they should fare well with CPX-based therapy, FLAG-IDA-based therapy, etc. But if there are MDS-related mutations that occur with adverse cytogenetics, they do not do as well. And that discrepancy between these two groups is something that would have been interesting to see, which I don't see in the abstract. Maybe it was there in the poster. The second part of it is how many patients went to transplant. More patients in the CPX arm were able to be consolidated, if I read it correctly, with more cycles than in the FLAG-IDA arm. And that is also important because FLAG-IDA is more myelotoxic than CPX. It is known there is more mucositis with FLAG-IDA as well. As a result of which there could have been non-relapse mortality in the FLAG-IDA arm, and that could have led to the survival upticking with CPX. But certainly, the message moving forward, or the studies moving forward, should try to incorporate both CPX and Venetoclax in the secondary AML space. So you have now two drugs which have shown benefit in AML with MDS-related biology, just moving beyond mutations, so cytogenetics and mutations, and combining these two might actually lead to significantly improved survival, and I'm looking forward to some of those studies coming out.
So just to just a follow-up question, if you see this patient right now in your inpatient service who has MDS-related changes, new diagnosis of AML, how do you treat that patient?
So if it is less than 60 years of age, our frontline therapy would still be a venetoclax-based dual nucleoside intensive induction, so CLIA-VEN or FLAG-IDA-VEN. So it will still be that. More than 60 years of age, and let's say we do not have any other targetable mutations, anyways, which is a rare NPM, meaning now we do consider NPM1 as targetable in our group because we have a menin inhibitor combo. Maybe we'll talk about it, but we do not see a lot of FLT3 in this group anyways. So short of that, we use a mutation agnostic approach. So cladribine, low-dose Ara-C, and venetoclax, and then we monitor them very closely. But certainly, we try to take them to transplant. Another thing in the NPM space, again, there have been many studies, some retrospective, some post-hoc analysis of trials that have tried to understand the impact of NPM1 mutation with secondary group mutations. All right. So these patients should not still be called genomically secondary AML because of the hierarchical structure of the ICC classification. So if you are NPM1, you are NPM1 mutated AML. This mutation should not lead to genomic secondary, but for discussion purpose, let's call them secondary type AML. So is an NPM1 mutated AML without secondary type mutations similar to NPM1 AML with secondary type mutations? So just hypothetically speaking, it is possible that there is more genomic instability in those who have secondary type mutations. There could be more clonal evolution in those with secondary type mutations. And again, very important data from UK NCRI group, UK AML group by Jad Oatman was published recently in Blood. Patients who had MDS-associated mutations, even if they became NPM1 MRD negative, there was a near significant higher hazards of relapse from the time point that they were MRD negative for NPM1 at more than 10 to the power of 5 level of detection. So these mutations, even if you are able to bring them into deep negative, we are judging only by one mutation, which is NPM1. We do not have deep sequencing clinically yet available for the other mutations. They still fare inferiorly than you do not have these mutations. Again, that study did not include venetoclax. Venetoclax could have a more global effect on the bone marrow in reducing the burden of the other clones, which could lead to the clonal escape. A lot of times, patients who are NPM1 MRD negative could relapse without the NPM1, though this is rare in other situations. NPM1 is a founder clone and it's usually retained at relapse. But if you're NPM1 MRD deep negative, your relapse could be a secondary clone coming up. Venetoclax would have a more global effect. But when you don't use Venetoclax, maybe we should still take them to transplant if they become NPM1 MRD negative.
So now moving on that discussion to talk about the most hot topic at ASH was about menin inhibitors. So
Certainly.
before going into the ASH, we saw that in November there was FDA approval of first-in-class oral menin inhibitor revumenib for patients with relapsed refractory AML and ALL with KMT2A rearrangement. This milestone was hinged on the data of the interim analysis of the phase 2 Augment 101 study. At ASH, we see an updated results of Augment 101, which included a cohort of 116 patients,
Right.
which showed a similar response rate of about 22% in this heavily pretreated patient population. And there was a prolonged duration of response, a median of 13 months, with 61 patients achieving MRD negativity.
Yeah.
And talking about the side effect profile, there were 15% of the patients who had differentiation syndrome in this updated results. And
Mhm.
there were also other side effects, including QTC prolongation, as well as cytopenias and febrile neutropenia. At the same session, we saw presentations about phase 1 data of bleximenib, which is another menin inhibitor from J&J Pharma, as well as enzomenib from Sumitomo, which was studied in a monotherapy in relapsed refractory AML with KMT2A and NPM1 patient populations, where we've seen a greater than 30% response in this monotherapy patient population. So Jay, so we are seeing, there is revumenib, which is already FDA approved, and we also know about ziftomenib, which is being studied only in relapsed refractory NPM1 patient population. And now we see some emerging data from bleximenib and enzomenib, which are being studied in relapsed refractory KMT2A as well as NPM1 patient population. So, what distinguishes these newer agents from revumenib, and what are the potential do these new agents hold?
Thanks. This is indeed still a very hot topic. Menin inhibitors, just revumenib got approved. And as the say in our department is by Dr. Kantharjan, real research starts after the drug is approved. So because it allows us to study different combinations and all of that. Now, the Augment study, of course, was the registrational study, Gasisa and Eatonstein and others. Now, if you look at the efficacy evaluable population, which is actually 92 patients, the CR/CRh rates were around 23%. In them, the duration of response was still 6.4 months, very similar to the enzomenib study, exactly 6.4 months actually in the enzomenib study as well. Now, of course, because of the approval of revumenib in this space, came to a translocated AML only, or came to a translocated acute leukemias only, I should say. Now the studies are moving forward with combinations. The COMET trial, which evaluated ziftomenib, certainly did not show that great an efficacy in the KMT2A space. It was more for NPM1. But also notably, there could have been slightly higher risks of differentiation in the KMT2A arm, because of which there was a hold for enrollment on the KMT2A arm. And NPM1 mutated seems to be the space where ziftomenib has shown better efficacy based on preliminary results. Now, bleximenib and enzomenib are still too early in their development, but we are seeing promising response rates, CR/CRh of around 30%, maybe some efficacy in patients who have received other menin inhibitors in the past as well. I know there is a bleximenib study that's open specifically for ALL as well. Now, how do these drugs fare with respect to safety is going to get more important to understand. Revumenib, a very well tolerated drug. Majority of these drugs have shown differentiation syndromes in the range of 10 to 15% as single agent drugs. But of course, we would expect these numbers to come down when we use them as combinations. Same with IDH inhibitors and others. So certainly moving forward, we'll be spoiled for choices for menin inhibitors, same as FLT3. just that the FLT3 space took 10 years to evolve and this took 5 years. So that's the only thing. The combination is where the buck lies, the safe combination led by Gus Issa and our group with a completely oral regimen of oral decitabine, which is the decitabine cedazuridine combination, venetoclax, and revumenib. Uh, Theoretically synergistic, and clinically we are seeing very high response rates in patients who have menin dependent leukemia. So thus far the study includes KMT2A translocated, NPM1 mutated, and NUP98 rearranged. So amongst, I think it was 33 patients that were updated. The phase 1b dosing was from 113 to 163. We are seeing overall response rates in the range of around 80%. And CR/CRh in the range of 50%. Essentially, these are still regimens which should take patients to an allogeneic curative hematopoietic stem cell transplant followed by menin inhibitor maintenance. But there could be patients who are not transplant eligible, and the duration of remission in these patients, 12-month DOR, 65%, of course, including those who were transplanted, is certainly promising, given that these are super refractory patients who would we have expected median survival in the range of 3 to 4 months in the past with supportive care. So there have been now a plethora of combination studies. So 7+3+ revumenib, and then different mix and combinations as you can think. And also in the future there are going to be studies which will look at MEIS-Hawks dependent leukemias. So we know there are a few, and I think this is another important area to address. MEIS-Hawks is the downstream proteomic pathways where there is menin dependency. And in more proximally, we are identifying them by the presence of KMT2A rearrangement, NPM1 mutation, NUP98 rearrangement, PICAM fusion, and things like that. But there could be a lot more. And maybe like we know FLT3 like AML, in the future there could be menin like AML, where these proteomic pathways are exaggerated, but we do not have the defining genomic aberrations proximally detectable. So in these patients, the assessment of the MEIS or Hawks upregulation is important. I don't know what would be the clinical way to do that, but it is relevant to understand. So these relapse refractory patients could still be treatable with menin inhibitors.
So I think you bring up a lot of good points, Jess. So I think one thing I noticed in all these four menin inhibitors which are presented is that cytopenia is one of the side effect profile seen in all these menin inhibitors. Although I think that should be taken with a grain of salt because these are all relapsed refractory patient populations, and you and I know that now this is usually these patients tend to have a lot of cytopenias. But still, I think we've seen a significant portion of patients having cytopenias on the clinical trial. How do you think a combination such as revumenib with oral decitabine and venetoclax in relapsed refractory patient population will be tolerated?
Right.
Do you have any concerns about the safety profile in these patient population?
Right. So you bring in a very, very relevant point, Ashwin. So uh, to start with is designing the combination. Certainly, if we are doing revumenib, which is the most important agent in these combinations, we have to cut short the duration of venetoclax. And in our practice, anyways, we don't do 28 days venetoclax. Even for other triplet studies with FLT3 inhibitors or IDH inhibitors, our venetoclax in cycle 1 is between 14 to 21 days. We do a bone marrow day 14 and then decide to continue day 21. Then if there is still disease persistence, we continue beyond that. And in subsequent cycles, the dose of venetoclax is further dropped. In the SAFE trial as well, the dose of venetoclax is shorter, and it's in the first cycle is dictated by what's the residual blast at day 14, and likewise. So that is the first step to understand. The second step is that these are patients who are super relapse refractories. Maybe some of them, majority of them, have seen prior venetoclax. Their bone marrows have seen prior transplants, so bone marrow reserves are poor. And certainly any form of cytopenia could become, or prolonged cytopenia could become deleterious for them.
Mhm.
But ultimately, the aim of these type of remission-inducing combination is to take them to an allogeneic stem cell transplantation. So in our practice, for all these patients, we try to proactively attempt a transplant to be set up as soon as possible. And the moment we see some form of bone marrow remission with or without count recovery, we try to take them to transplant. Now, in patients who do not have who do not have count recovery and are not transplant candidates, the duration of cytopenias are going to become relevant. We will have to, meaning we know that menin is cytopenic, and when we combine with venetoclax, this becomes cytopenic. But at the end of it is the leukemia, which is also driving a lot of the cytopenia. So if you're able to get true deep remissions, some of these patients do recover counts even without transplant and can have transplant censored good duration of remission and survival. But we'll have to see these data to mature more and understand grade 3 and more infections or non-relapse mortality secondary to cytopenia. Those data are emanating, and we will look forward to them.
Fantastic. Now moving on to talk about FLT3 inhibitors. I think we have seen some interesting updates. The first one is the PRECOG 0905 trial, a rare head-to-head comparison of novel agents in AML. This is a randomized phase 2 study which pitted midostaurin against gilteritinib plus 7 plus 3. As a background, we know that midostaurin was approved in upfront therapy with AML with 7 plus 3, and gilteritinib, which is a more potent FLT3 inhibitor. So this is the trial which compared midostaurin versus gilteritinib in the frontline therapy, looking at remission rates, MRD clearance, as well as transplant outcomes. This is a big randomized study which included 177 patients between 18 to 70. The study clearly showed that gilteritinib improves remission rates and transplant eligibility compared to midostaurin in this newly diagnosed FLT3-mutated AML populations. But the MRD negativity post-induction was no different, as well as we've seen that there was a higher CR rates in patients with FLT3 TKD patient populations, which was very interesting to see, who derived the most benefit of gilteritinib compared to midostaurin. So, Jay, so what is your take on this gilteritinib versus midostaurin? Are you surprised to see that the FLT3 ITD patient population did not derive the benefit we were expecting? Only the TKD population where we have seen a benefit.
Thanks, Ashwin. Again, this study actually puts more questions than answers. Good to have a head-on comparisons study in this space. Certainly, a lot of institutions had moved towards gilteritinib and now quizartinib, of course, after the Quantum Force trial. Again, remission rates were higher with gilteritinib in this study, which is important because at least that will define your ability to take a patient to an allogeneic stem cell transplantation. We have data now to show that if a patient reaches FLT3 MRD negative, the question about transplant becomes a little, do we take them to transplant or not? There have been data that shows that maybe, without transplant or even the benefit of maintenance in this space is debatable, but certainly thus far practices have usually not changed. Patients with FLT3 mutated AML, if they are transplant eligible, transplant remains the standard of care. So attending a CRC is the first time point or the most important basic requisite to take a patient to transplant. Now, amongst the patients who attained a CRC, we see higher rates of FLT3 MRD negativity with midostaurin than gilteritinib in the study, which is very relevant finding. But I would like to know what was the VAF in these patients who received CRC to start with. Maybe there were patients that for some reason were selected to have, I'm not saying it was selected by choice, but it was selected, by chance, that these were patients who had lower VAF and they attained CRC, and as a result of them on the midostaurin arm, they had deeper remissions with MRD negativity, but that will still not entirely answer the question. I really do not have an answer. We'll have to go back to the basics to understand how midostaurin inhibits FLT3 compared to gilteritinib. The high degree of FLT3 MRD negativity with midostaurin might rejuvenate the drug significantly, actually. But we do not use a lot of midostaurin in our group per se. We have significantly weighed in our options with gilteritinib, and now a lot of trials are going on with quizartinib and fantastic results uh, with low intensity triplets as well as intensive chemotherapy combinations with gilteritinib or quizartinib. But this is interesting data. And the other part of it is with TKD. Meaning we still do not know the impact of TKD based, the impact of FLT3 TKD on prognosis, especially if patients are receiving Venetoclax. ITD certainly is inferior, leads to inferior outcomes, but good to know here that FLT3 TKD also did well, I guess, with gilteritinib than with midostaurin in this study. But the ITD part of it remains surprising and positively surprising.
So, just to follow up on that, if you see a newly diagnosed AML patient who is younger than 60 with the TKD mutation, would you add a FLT3 inhibitor or would you hold off?
A lot of time, this decision is based on the allelic ratio of the TKD. If it's a small TKD, we usually go ahead with venetoclax based intensive induction therapy. If there is a high allelic ratio, then we'll probably add gilteritinib to this TKD, provided there are no guiding mutations. In the low intensity treated patients, if somebody has a FLT3 TKD with a reasonably high allelic ratio, we will try to treat them with a triplet of gilteritinib. So maybe our azacitidine venetoclax gilteritinib combination. If they have other guiding mutations, for example, there is an IDH1 or IDH2, then, and if the patient is not very proliferative, then we might end up targeting the IDH mutations. But a lot of it is again dependent on the allelic ratio of the FLT3 TKD, the presentation, and the presence of concurrent mutations.
Fantastic. Now moving on to talk about a couple of abstracts from MD as well. I think one thought-provoking abstract in MDS is when should we use ESAs in lower risk MDS? There was a phase 3 EPO-PRETA trial from France, which evaluated early versus delayed use of erythroid stimulating agents and found no impact of survival as well as quality of life in early introduction of ESAs versus delayed. And there was also no effect on PFS, AML transformation, quality of life, and survival.
Right.
So this was, at least in my opinion, it was quite thought-provoking because we have seen from deletion 5q low risk MDS Centra Rev trial, where lenalidomide has shown benefit in earlier intervention,
Right.
where it showed a delayed transfusion dependency in patients with anemia who were not transfusion dependent. And
Correct.
this result sort of conflicting with this results where early versus delayed, there was no difference. So how do we recommend a community oncologist who majority of the time see these patients whether to use ESCs early on when they drop to hemoglobin at 10, or do we wait until they are transfusion dependent and start ESAs?
Right. Thank you, Ashwin. So, few questions in this analysis. Again, the study appears very well balanced in the two arms. Nice study design for sure. Uh, but the bigger question here is how do we incorporate luspatercept in these patients, which has already been shown to be
Mm-hmm.
superior to ESA, even in treatment, meaning patients who need transfusions and have never seen ESAs before. Time to transfusion dependence was not different between these two arms.
Right.
Uh, and again, we cannot discount the side effects of EPO, maybe in a subgroup of patients with cardiac comorbidities, etc. Though low, but still something to consider upon, especially because there was no difference in transfusion dependence moving forward. The other thing to ask is traditionally we have looked at the need for transfusion, the need for transfusion or the need for transfusion like medications for progressive anemia to start at around hemoglobin less than 10 is when we start to propose patients to get these medications. A lot of these patients might, however, have alteration in quality of life at slightly higher hemoglobin levels, 10.5, 11. So that way, this study still included patients who were around 10.5 and lower. So tries to answer that question, but I do not think meets the endpoint, which was transfusion dependence. And especially when we have drugs like luspatercept, which has more biological relevance, I think it does not really changes practice at this point. With respect to the Centraref study, meaning lenalidomide and 5-q minus, there is a strong biological rationale to that, and there is a possibility of cytogenetic remission in these patients if you induce them early with lenalidomide-based therapy. Majority of these patients had lower hemoglobin to start with, but still not transfusion dependent, and that increased the time to transfusion dependence. Here in the late transfer. In majority of patients in the other arm here had hemoglobin 9 to 10.5, slightly on the upper side. So I don't know if we can compare it directly with the Centraref study, but the fact that, EPO in this study was used across the board, not specifically for any specific genomic subgroup of MDS, I don't think it will change practice for a lot of people. And certainly the present practice remains to use these agents when the hemoglobin is dropping or patients are becoming more gearing more towards transfusion will probably still stay the course.
Yeah, thanks for that. Excellent points. Just to briefly talk about one other abstract, I think, which was
Yep.
quite thought-provoking, was the ATRA in MDS. As we all know, we use ATRA arsenic in treatment of acute promyelocytic leukemia, a
Yep.
subtype of AML.
Yep.
But right now, we have seen a randomized controlled trial from China, which showed that adding ATRA to decitabine improves response rate and progression-free survival in high-risk MDS. So MDS with excess blast is what they included. And the authors speculate that mechanistically, ATRA blocked NRFT activation induced by decitabine, and that's why leading to ROS accumulation, and that can cause ROS-dependent cytotoxicity. This was a huge trial of 227 patients who were randomized to ATRA plus decitabine versus decitabine, equally balanced between both the arms, and response was assessed after 4 cycles of treatment, which is what normally we do in clinical practice as well.
Right.
And the overall response rate was 78 in ATRA plus decitabine versus 51% in decitabine only arm. And the CR rate after 4 cycles was 23 in ATRA plus decitabine versus 12.
Yeah.
But the coming to the most important endpoint, which was the median overall survival, there was no differences.
Yeah.
23 versus 19 months.
Yeah.
So, what is your take on this very interesting study from China?
It's actually a pretty big study, and it shows significant difference in both overall responses as well as complete remission. If I'm not mistaken, complete remission was almost double with
Correct.
ATRA and decitabine, 23% versus 12%. And there was a slight improvement in progression-free survival as well, 14.9 months versus 10.5. The overall
Mm-hmm.
survival was not super different in the two groups. I think the data is still preliminary. There is biological data that was shown here that could explain why ATRA is synergistic to decitabine in this space. Certainly in the high-risk MDS space, we are looking forwards to the Verona study, and
Yeah.
and that would give us a lot of meaning. Unfortunately, not many studies have been successful. We are still mostly dependent on HMA in the approved setting for this, and then there are clinical trials of HMA plus Venetoclax, etc. This, of course, needs to be pursued again in a bigger fashion, probably, and this increase in response rates might make transplant more eligible in some of these patients with high blasts. So more patients could be facilitate to proceed to an allogenic stem cell transplantation in better remission status. And I think this is promising to evaluate new agents in the high-risk MDS space where, unfortunately, there is a dearth of agents. And I would have liked to see the genomic, the mutation profile, the cytogenetic profile between the two arms. I understand this was not genomically inspired, so all comers with EB1 or EB2 could get in. But maybe there are signals of specific sensitivity of ATRA-based therapy in some groups. There were some interesting data about RUNX1 mutated AML and ATRA. However, in the clinical space, this hasn't panned out much. But it would have been important to know what were the mutation and the genomic profile, and I'm sure the authors of this study will update that when they are proceeding towards publication.
Fantastic, Jay. So thank you so much for discussing some of the thought-provoking and interesting abstracts from ASH, and thank you so much for your time.
Thanks a lot, Ashwin, for having me. Looking forward to participating in Blood Cancer Talks podcast in the future as well.